Hello, welcome to Fertility Fact or Fiction. I am your host, Dr. Rahi Victory, a Canadian and American board certified reproductive endocrinology and fertility specialist. And tonight, we don't have a topic. So we are just going to answer your questions on Fertility Fact or Fiction. And I want to say thank you to everybody for sending in questions in advance this time. We have 55 to get through. So even if I'm really quick, I'm not sure we'll get through them all, but we will do our best. And I have my very good friend Tarek Ibrahim from Ibrahim Strategies Group with me. He'll be reading out the questions and I will do my best to answer. So if you have live questions, feel free to ask. We will try and go back and forth a little bit, but we're going to try and get through all the ones that were asked online ahead of time. So if you did ask your question online, please stay on because I can't answer them all simultaneously, but we will answer.
Huge one just came on Facebook.
Oh, huge one just came on Facebook. All right, already.
It starts with high T.
Yeah.
High T, Dr. Green.
Yeah.
I did a modified natural FT with 2.5 milligrams dissolved.
Okay.
Trigger 5,000 Prenatal. At 3 follicles, 20, 19, 20. And I'm certain they all released.
Okay.
The day before transfer, my progesterone was 29 nanograms per minute. I retested progesterone 5 days later and it jumped to 85 nanograms per mil.
Yeah.
I'm only on 0.5 milliliters PIO in olive oil daily. I skipped one dose after transfer because I had such a bad in PIO. I am very progesterone sensitive, including to the additives in them that don't do well with suppositories.
Sure.
The rapid increase of progesterone have harmed any chance of implantation. What could explain such a quick rise? Could it be Could it be 3 CLs releasing that much progesterone?
Yeah.
How much progesterone does 1 CL release? Can that cause more harm than good for some? That's cool. Some people because of this. Why can't I find any studies on what the progesterone numbers should be after embryo transfer and how to manage that? Thank you. I believe that's how it was said.
Okay, so thank you for that graphic display. Okay, so yeah, you were on essentially birth control levels of progesterone, unfortunately. So that is way too high. So one of my concerns when I'm using letrozole, which we do for all of our FETs, is not necessarily letting the eggs release, because if they do release naturally, overshoot your progesterone levels, you get way too high. If you're at a 17 and 18, or at plus minus 12, the 12's question, you're definitely going to be producing substantial progesterone levels on your own. Those are cases where you don't really need PIO, and you can just add a little bit in, but you probably don't need very much. Certainly not 0.5. I'd be using like 0.625 milligrams. So or milliliters. You're going to be on, or milligrams, sorry, you're going to be on super low doses. Because even a tiny little bit and you're going to overshoot. So when you had your 29 nanograms per mil, that's actually the upper limit of where you want it at. You want your progesterone in nanograms per mil between 10 and 30, and in nanomoles per liter between 40 and 100, unless, like we demonstrated last time, you have endo, in which case higher numbers are acceptable. But 84 in a nanogram per mil, that is way too high. So I would not use PIO. Now, that's not to say you can't get pregnant with that. You may very well get pregnant. I'm sure loads of people were getting pregnant in the past when we were doing more fresh IVF cycles, and all of those sucked out follicles did become corpus lutea. They probably had sky high progesterone levels. But I don't recommend it getting that high, because it's much higher than you're supposed to keep it. So you're kind of overshooting the mark.
Doctors use before 42 weeks. I prefer 40 weeks for safety. Anything I can do at
home? Okay, so anybody that doesn't induce between 42 or before 42 weeks has absolutely no clue what they're doing. So that's someone you should just be switching from, because there is very good evidence that after 41 weeks, the rise in stillbirth risk and placental failure and significant complications, including meconium aspiration, NICU admission, fetal death, morbidity, all that's way, way higher. 42 weeks has a 700% increase in stillbirth risk. So to review the ARRIVE trial, it's called the ARRIVE trial, where they demonstrated that induction at 39 weeks is actually better. And if you need help, we have an entire video on it with actually quite a lot of views now. I think there's like 24,000 views or something on inducing pregnancy. So don't hesitate to go look at that video because it should be called Inducing Labor. So we do need to change the title of that. It says Inducing Pregnancy. But you need to go look at that because it's very clear from the data that you're going to do much, much better with a induction of labor at 39 weeks than you are at any other time. If your doctor's not willing to listen, go to another doctor because they're endangering you and your child.
41 antagonist, 450 full, 150 mino HCZ trig, 1 to 2 class abnormal. Should I lower meds?
450 units of Menopur?
Yeah, 450 FOLL over 150 mino HCG trig.
Oh, 450 falls to 150 Menopur. Yeah, I mean, that's kind of a high dose. We don't go to 600 anymore. We use like 225 max. We try and stay below that if we can. I mean, your aneuploidy risk is related to your age, and at 41, you should go into it anticipating an 80 to 90% risk of aneuploidy. Standard, actually, a lot of embryos to just be able to find 1 or 2 that are normal. Unfortunately. So I'm sorry. Our embryo math video explains that. So check that out on YouTube. It's the most popular video on our series there. So it'll tell you how many tries you need, and it's quite a few. So yes, I would reduce your dosages. I would balance out your dosages to half for Follistim and Menopur because recombinant to urinary should be roughly half to minimize the chances of aneuploidy. That's from a big British study we reviewed like 3 or 4 years ago. So check that out. But I would use like 225 Menopur, 225 Follistim or Gonal-F or Irregular.
I need surgery for a 6-centimeter chocolate cyst.
Sure.
What are the risks of a negative impact on fertility?
Well, with a 6-centimeter chocolate cyst, you're kind of damned if you do, damned if you don't. The longer you leave the cyst there, the weaker your ovary is becoming, and removing the cyst will also weaken your ovary, although they've shown that the effect of that only lasts about a year. So I don't think with a 6-centimeter you have much choice. You really kind of are obliged to take it out. So I would make sure you take it out, but the method that they use to remove it is incredibly important. If you go in and you just split the ovary in half, rip off the top half, and then scoop out the bottom half of the cyst, which is technically really easy to do, you're losing half of your ovarian tissue, so you're doing an enormous amount of damage. And that's called de-roofing the ovary. So make sure that that is not the technique they're going to use. What they actually have to do is take your ovary, make one tiny cut across the surface, open it, and then scoop out the inside, almost like scooping out an orange without removing any of the peel. And then once you've done that, you're still protecting all of the ovary and you're doing the least amount of damage possible. Never let them cauterize your ovary, even if it's bleeding. There are hemostatic agents that can be used. Do not use cautery, it damages all the eggs in there. And then even for doing the actual surgery, you want to use something like the harmonic scalpel and laser to try and do as little damage as possible to the ovary as you're doing the surgery to even cut it and go and shell out the cyst.
Hey, Dr. V.
Yeah.
Found out today I have an interior placenta.
Oh,
does that come with any risks?
As long as it's not low, it comes with no risks. So you know what? That's a good picture drawing. Yeah.
All right. They are ready for you.
Whoops. Okay, so if this is your uterus, and that's the inside of the uterus, and I'll do the placenta in red. So if your placenta is in front of your cervix like that, then that's dangerous. And if it's in the front or back, it doesn't matter. If it's in front of your cervix, that's a problem. But if it is away from there and it's in the front, like let's say this is the front of your uterus over here, so it can be in the front, but as long as it's away from your cervix, you're fine. So if I show you in a completely different way, you look at the uterus this way, sideways, and if your head's kind of up, if the person's head, why is that not drawing, is up here, and their feet are down here. So obviously, if the placenta's in the front, I'll do the placenta in blue this time, it can be on this wall. That's fine as long as it's not down low here in front of your cervix. So that's all you got to worry about. Otherwise, no risks.
Recurrent implantation failure,
Mhm.
3 cycles, 5 embryos. What tests are absolute must for next try?
PGT for your embryos, thyroid check, vitamin levels, sperm DNA fragmentation for your partner. Your BMI needs to be noted. Find out if either of you are smoking, drinking, or using drugs. Fertility testing, and Fertility just, I was on the Zoom call with him yesterday in Greece, where he was explaining this new set of tests he has for KIR testing for HL type matches, which he believes is very significant. So we're going to start adding that to some of our testing as well. So you want to do the fertility infection test and the immunological testing. Thrombophilia screen we would add in there as well. That's kind of what we would start with anyways. You need a consult, so reach out to us. That's kind of a lot of what we do now is help people that have had failures, and we set them on the right path and then they get success.
2 mature follicles, but 4 that could catch up. Cancel the IUI. Right choice?
Yeah, probably the right choice. So, if there were 4 that were close, your options are to drain them so they can go in and do a retrieval, and just charge you a couple $100 for the retrieval, and then do the IUI. And we've done that before for people that over respond. But I have had cases where we had one patient once upon a time who had 3 good follicles, 3 that honestly were not even close. They were not at the point where we thought they were mature, and she ended up with quintuplets. So I never want to see that again, ever, under any circumstances, for any reason, because that's a disaster. So we would strongly advise you to either cancel the IUI or to retrieve the other eggs.
Is it necessary to be put on birth control pill for the IVF cycle?
Absolutely not. In fact, in many instances, you should not be on a birth control pill prior to an IVF cycle because the risk of ovarian suppression is higher. The chances of success in some studies has been shown to be decreased. So the miscarriage rates are supposedly higher. So that's from Kolobanakis study from years ago. So yeah, we don't use it a lot. We do use it for some patients, but you don't need it for a lot of patients. Mostly just the PCOS group is the group that you would look at doing the birth control pill for.
When is a low dose IV protocol beneficial for a patient?
Poor response to high dose. You're not making a lot of eggs anyways. If you have a really low AMH, some people like pound the ovaries to try and get them to make, 5, 6 eggs, when in reality you're only going to make 1 or 2. So that's a perfect opportunity. You just take low dose. Religious reasons, if you don't want to make a lot of eggs, those would be the main ones. We're actually getting through.
What does Pepsid do in a I keep seeing women on it for FET.
Yeah, so Pepsid's an H2 blocker or an H1 blocker, and then there's other H2 blockers as well, like Benadryl. So some people are on these like Benadryl and Pepsid combos. I looked it up. I could not find a single shred of evidence that suggested it was beneficial. There are people that use it. They think it is immunologically helping to suppress your immunoreactivity. I don't believe it does, but there are people out there that do.
IVNT. My doc won't use Lexapro for FET without a study. Is there one? One. 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 Is there one? Says it will thin my lining. Is this true?
No, it doesn't thin your lining. That's been proven time and again.
I
And
should
there,
say with this doctor.
yeah,
I
and,
can't educate
and we have multiple studies. We have them all over the place. We've got multiple videos on it with the study in the video. If you go to PubMed, oh, let's just do it. That's probably easier. Hang on a second. Let me pull up PubMed. Yeah, go ahead. Okay. So if we go to PubMed and I type in letrozole and FET, just as simple as that. No, not vet. Oh, for God's sakes. And FET and hit search. You don't just have one, you got 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. There's 31 results total. You can see it at the bottom there. So tell your doctor that they're not following recent data.
Or any data.
Or any data for that matter, yeah. Just go to PubMed. Take your phone or take your iPad. All you got to do is go to PubMed, PubMed.com, and then you type in letrozole and FET and hit search, and a whole whack load of articles are going to come up, all of which say the same thing, which is it does better. So it's pretty straightforward, and it does not thin your lining.
Hi, Dr. V and Doc T. Yes. This is it.
This is why he comes here week after week, is to get his honorary medical degree.
I go home and get slaughtered. I come here on top of the world. This is my new sanctuary. Doc T, ladies and gentlemen.
Doc T. Ladies and gentlemen, Doc T.
I've been on Lupron Depot for 6+ months to suppress endo while waiting for IVF.
Okay.
How long could it take to get a cycle back now that I'm off? Last month injection was under 30.
Well, it depends on which injection you're on. It'll probably take 1 or 2 months, but Lupron prior to IVF has been proven to not be beneficial. Vizan prior to IVF works, but Lupron has actually been studied as not beneficial. Lupron plus letrozole prior to FET is beneficial, but Lupron alone has been studied. It does not help. So don't do that anymore. It's not helping. It's suppressing you.
Hello, awesome team.
Okay. See, that's good. Thank you.
Wondering if Dr. V,
yeah,
I guess this is
for me, yeah.
Has a favorite brand of prenatal vitamins and probiotics to recommend.
Oh, yeah.
I keep rotating mine every month, not for any reason other than switching things up. Is that okay?
No, don't switch things up. Your body doesn't like that. So we use a lot of Pregvite and we use a lot of the NFH product. Jennifer Strong, Dr. Jennifer Strong, and myself did a video called The Good, the Bad, and the Prenatal. Is that what it's called? On YouTube. It's pretty popular. We've got a couple thousand views on that too. So check out that video because we actually compared each and every one of the commonly available brands of prenatal vitamins, and she went through which ones are the best. In her opinion, and she's the naturopath, so I trust her, the NFH product was the best, and the next best is Pregvite Folic 5. So take your pick. Materna and Centrum Prenatal were on there as well. And then there was a Kirkland brand. I think those were all the ones we had. So yeah, just check that out and see what you find there.
What would cause an endo patient with Lupron shots to not achieve a trilaminar lining?
Excessive suppression, and where you're not able to get enough estrogen, damage to your lining. Um, those would be the main things that would happen. If there's any scarring, infection, anything like that, that could do it. But number one thing I'd be thinking of is excessive suppression of your ovaries and your lining so that it just doesn't want to respond. We got a doozy?
No, you just got, yeah, I guess like we got disease.
Okay.
Hi, Dr. V and T. Just want to say thank you for everything. These
Oh.
sessions are quite important.
Oh, you're welcome. Thank you for watching. We love doing this show.
With endometriosis,
Yep.
would you do Lupron or Elissa prior to FET? And if so, for how long?
Lupron and letrozole for 3 months prior to an FET has been proven to be beneficial, in theory, for patients with endometriosis. It was for unexplained failures, but they assumed that most of those patients had endometriosis, and it makes sense. So that's our protocol. We do Lupron and letrozole for 3 months prior to doing an FET. Or Elissa, there's no data, so we don't know. Maybe it's good, and it probably would be, but we don't know.
Do you have a favorite brand of prenatal vitamins?
Oh, same one.
Same one, but different one.
Is it really?
Mm.
Same one, but different one? Yeah, prenatal vitamins. I don't support any particular drug or product. We're actually not allowed to in Canada. So I'm not going to say this one's better than that one, but I will say that Dr. Jennifer Strong thought the NFH product was better, and then the Pregvite 5. That was purely based on the dosages in the vitamin. So it wasn't that we preferred one over another in terms of the product. It was the chemical contents of what was in there. I don't care who makes it or what it, what company it is or where it's made or any of those things. It's who has the closest to the recommended daily allowances of what you need in pregnancy. So the two that are best for that are NFH and Pregvite 4. But we don't promote one product over another. You take whatever you want.
PCOS.
Okay.
3 unsuccessful IUIs.
Okay.
With gone left.
Wow. Okay.
Should we just move on to
Yeah, you probably should. It depends on your age, but I mean, if like PCOS, we would never jump straight to Gonal-F. We would usually go letrozole, and now we reviewed that study where they used 3 days of Menopur, so we would do letrozole and then 3 days of Menopur and see what kind of chances we got. If you've already done full stims with Gonal-F and it didn't work, yeah, I would move on to doing IVF.
Good evening, fiction dudes. I don't make this stuff up.
You know what? We should get. We need like a jacket or a T-shirt.
Shirts, jackets, something at this point.
Yeah, someone wants to get us to coin the WWDVD. What would Dr. Victory do?
Oh, I like that.
They like that. Yeah. That WWDVD. I thought that was.
You know what? That's not bad.
That's good. Yep.
What is standard dosing
for
follicism and Menopur starting doses?
For fall stim.
For fall.
There is no standard starting dose. So it depends on your age, your AMH, your body mass index, how many follicles you're aiming for, what your history is. There's no such thing as a standard dose. So I'll give you some examples. If I had a 30-year-old healthy, fit, she's got a high AMH, I might start at 125 each or 112.5 even, maybe 150 each, like Menopur and Follistim. If I had a 41-year-old and her AMH is like 9 picomoles per liter or 10 picomoles per liter, she may need 225, 225. So there is no standard. If you have a younger lady that's heavier, she needs more. If you have an older lady that's thinner, she needs less. So it all depends on the circumstances. There is no standard dosing for any drug. The only one that's standardized is Recavel, which is coming to the US soon, but we've had it in Canada and Europe for a while. And Recavel is purely based on your body mass index and your AMH. So it's a calculated dose, and it's just done based on the the nomogram that they have. So they don't care about any of the other features. And they validated that in targeting a certain number of eggs. I don't always follow their instructions, but it does work really well, and it is a great drug.
I'm going to fast forward a little bit
Okay.
because it caught my attention. And I'm assuming you might give it a good reaction.
Okay.
It's all for the reaction here.
Okay.
Hi, Dr. V&T.
Yeah.
Listen to this.
Okay.
She obviously got my.
Yeah.
I failed 2 embryo transfers, going for the 3rd.
Yeah.
Emailed my RE to ask what he thinks of letrozole versus estrogen protocol.
Right.
His response.
Yeah.
There's no advantage.
Oh, that's not true.
I'm coming to you.
That's awesome. Yeah. So there is an advantage, and we just showed that, I think it was 3 weeks ago on the show. They compared head to head letrozole, natural, and hormone replacement. Hormone replacement has the lowest success rate. So to say that it's not better is just absolutely fallacious. That's incorrect. It's not right. It's amazing how little. Yeah. So the Fertility guy, I didn't get the chance to tell you this. He gets consults going directly to Fertility, and people contact them because they know they're doing all this cool testing. And so he said, we're looking for a clinic that we can refer those patients to. And he and I talk all the time. And he said, you're the only one that reads as much as you do. So we're sending them all to you. So we're actually getting all the Fertility patients. Yeah. I don't know how to manage all these people, but
I think I'm going to become Dr. T.
I think you need to become Dr. T. That would be helpful. Yeah. Yeah.
What's the difference between Centratide,
Orgalutran?
and microdose Lupron to prevent ovulation?
Microdose Lupron you've got to use at the start of your cycle to prevent ovulation, and it's very good at promoting the growth of eggs in the beginning. That's the reason we use microdose Lupron. Orgalutran and Centratide are essentially the same drug. They're both GnRH antagonists. So you don't start them until the follicles are about 12 to 13 millimeters. So once you start them, they prevent the release. They don't promote growth, though. They actually kind of retard growth. So you're going to use a microdose flare if your ovaries are weak. You're going to use an antagonist if your ovaries are strong or normal.
Best protocol for immature eggs and low AMH.
DHEA for 3 months. Testosterone priming. There is a new study we'll probably review next week, which shows that testosterone priming is the bomb. Use human growth hormone shown to increase the number of mature eggs. Make sure you double trigger and make sure that they're not triggering you too early. So some places are a little crazy and they're stuck on numbers and they're just going with like 16 millimeters and it's time to trigger, or 17, or as soon as we get 2 that are 17. It doesn't work like that. Like, you have to judge estrogen levels and how your hormones are going and how big the eggs are and how many are there. You can't take this like super cookie cutter approach. I know I say that to death, so I'm sorry, but cookie cutter approaches in fertility just don't work well at all.
For PGC test results,
Yeah.
do you allow them to share mosaic results?
Yeah. We tell everybody low-level mosaic is now considered normal. High-level mosaic has virtually no chance. So we always share our mosaic results with our patients. Why wouldn't they? To whoever wrote that, can you please just jump back on and tell us if your center actually is refusing to share that with you? Because that's illegal. You cannot not give patients their own health information. So if that's what they're doing to you, regardless of which country you live in, that's like absolutely not okay by any stretch of the imagination. And the medical information is yours. It's not the lab's. So they have to give it to you. So yeah, just tell them to give it to you. I hate stuff like that. Isn't that annoying? Yeah, I hate it.
One of the reasons I love the show is to hear the wild stories that other people are unfortunately.
I know. And it's
my mind.
And it's good because I like empowering people to.
That's what you're doing for sure.
I like that. 100%. I like empowering people to be able to get what they need from fertility specialists. Yeah.
Intralipids contain egg lectin.
Yeah.
If I had a severe egg allergy
Oh,
as a child,
no, don't.
but can eat eggs fine now, can I still receive intralipids, or should I pursue IVIG?
Well, IVIG is psychotically expensive, but is the gold standard. So if you can afford IVIG or you have coverage for it, sure, go straight to
They
the
have money
IVIG.
flying away after you.
Yeah. If you don't, I would just go see an allergist and get skin tested for intralipids. So they'll inject a little under your skin. If you don't react, you're fine. That's an easy test.
Can I receive immune treatments for infertility without IVIG?
Yes, you can receive immune treatments for infertility without doing IVF. We do it all the time. One of my favorite cases, this beautiful young lady who had so many miscarriages, I've lost track. And we finally did a bunch of immune treatments for her, and she ended up with twins. So, and they're so cute. So, yeah, we do that all the time, and we're very happy to do that. And it was just IUI; it wasn't IVF. Even if you just want to try natural, but you have an immune-mediated problem, we're happy to do that for you.
Will you be taking magnesium, and what form?
You know, I saw an Instagram post the other day about magnesium and infertility, and that you need to increase your magnesium. Uh, if Jennifer Strong is watching, Jen, text me and tell me if people need more magnesium. I'll keep my phone handy. If they don't need more magnesium, that's fine. I'm not aware of data on that. It's more of a naturopathic approach than a Western science approach. I'm generally pretty good with the naturopathic stuff, but I don't know specifically about magnesium. We'd have to look it up. You can ask me the next one while I look at magnesium.
Should I use Provera to induce a cycle before starting because for IVF?
Yeah, you can do that. You absolutely can do that. You can use Provera first, but it won't regulate your cycle. So that's one where you could use birth control, or you could use Provera and then take letrozole and then start your cycle off the next one, because that'll actually sync your cycle so it's working properly.
Does the use of Clomid cause polycystic ovaries?
No, Clomid makes you make multiple follicles, in which case you may develop several follicles, which can look like cysts. And Clomid can cause cysts, but it doesn't cause polycystic ovaries. Well, let's see. Metabolic and hormonal effects of melatonin and or magnesium supplementation in women with PCOS, a randomized double-blind placebo-controlled trial with someone that has my mother's maiden name as their last name.
Hey.
Yeah, that's kind of cool. This is an Iranian study, God help us all. Co-supplementation with magnesium and melatonin, so they put together both, had beneficial effects on sleep quality and total testosterone. Additionally, melatonin supplementation alone was found to be associated with a significant reduction in the PSQI score. Combined melatonin and magnesium supplementation was more effective in improving the serum levels of cholesterol, low density cholesterol, high density cholesterol, insulin, and your HOMA-IR. Well, that looks pretty impressive. So maybe we should be putting people on oh God, more stuff to put people on. There's another one from the same group looking at the impact on biomarkers of oxidative stress, serum magnesium and calcium. Yeah, you know what? I'm going to have to look this up, guys. I will look it up and find out. And by the way, we're going to try something cool. You remember years ago, someone asked us about red light therapy?
Yeah, all the time I remember that red light therapy.
Yeah. So it's actually lasering the sperm. You hit the sperm with a laser to inactivate it, because you have to paralyze sperm before you inject them for ICSI. So we're going to try. It's supposed to be good. So I know. Well, the thing Dr. Yeah, we're going to try it. We have one client from Colorado, and we're going to try it for them to see if we can improve what we did for them. Yeah. They actually did better with us than they had in 2 or 3 previous cycles, and and now we're going to try and improve even on what we already did. So it'll be cool.
And Dr. VT.
That's us.
That is us. I have a patient at your clinic.
Okay.
They're starting a frozen embryo transfer.
Okay.
I'm wondering what to expect within the next month or so to prepare for the transfer.
So usually a Lupron shot, and then letrozole day 3 to 7, antibiotics, then probiotics, melatonin, vitamin D, lots of vitamins, your prenatal as well, of course. Who knows, maybe magnesium if it turns out that we need magnesium. Lots of monitoring with ultrasounds, estrogen only if we absolutely need to, progesterone in oil, vaginal progesterone, more monitoring, and then your embryo transfer.
Try 2 times IUI with no success. Okay. Thinking IVF for last 5. Protocol suggestions? Thank you.
Oh, I need way more details about you. I need your height, your weight, your habits, your number of eggs, your AMH level, your antral follicle count, the sperm quality, how many kids you want. I can't answer that without knowing more details about you. Why do you need the fertility help to begin with? So that's a great question, but it's too lacking in detail for me to be able to answer.
Can uterine polyps cause infertility?
Yes, half the success rate and double the miscarriage. So that's a no-brainer. Get your polyps removed.
How can you improve response to symptoms in poor responders with good AMH AFC? Yep.
So that's unusual. I would try different drugs, or I would try a different approach. So if you use birth control pill, don't. A lot of people ignore the fact that early in the cycle, if you're on the pill or you were suppressed, if your LH levels are really low, like in the decimal places, you won't respond to any medications. So you got to make sure your LH level is reasonable. Microdose flare will wake up the ovaries. That's where that Lupron microdose will work. DHEA, testosterone priming, human growth hormone all help. Any of those things should facilitate a response. And then sometimes you do have to kind of give higher doses to start and then drop them down. So that's a reasonable approach as well.
Best thing I can do to prepare for IVF. I'm diagnosed with endometriosis, 33 years old.
Resveratrol, NAC, curcumin, coenzyme Q10. Take the Zan for 3 months before your stim. Eat super healthy. If weight's an issue, try and lose the weight. Get your partner to be healthy as well. No smoking, no drinking, no drug use. That's pretty much all you can do. There's not a lot more.
I'm writing that. Is there still a shortage of Cetrotide, and are there any replacements / alternatives?
You can use Orgalutran. You can use Cetrotide. You can use the long protocol, which is Lupron down regulation, or the microdose flare protocol. There's all sorts of different options, but those are the main ones. It's Orgalutran and Cetrotide right now. I think it's back and available now. I think it was just a shortage until mid-October, and it should be back now.
Does the guy still need to take every day even after successful 19 egg retrieval and 13 frozen, and now preparing for the transfer in a few weeks, or should the guy stop?
Yeah, so that's a great question, and thank you for asking. Men with poor sperm quality actually have much higher risks of multiple health conditions, including bad stuff like early death, colon cancer, prostate cancer, loss of sexual drive, muscle mass loss, all sorts of things, bone health, bone loss, if they have poor quality sperm. So it's important as a man or as a male, to keep your sperm quality optimal all the time. So if he went on Profertil because his sperm wasn't great, keep him on the Profertil.
The same girl that said, listen to this.
She's back.
Not done. Not done.
Okay.
This is some more.
Okay.
Save Party
Yeah.
also said, fertility, I did on my end because I follow your show,
Okay.
is a waste of time. I'm glad I know how to advocate for myself. Excited to come to you for my number 3 try.
Wow. So listen, there are no direct tests that demonstrate that fertility testing, because I want to be really open about this, actually directly benefits anybody's IVF outcome. However, we know very clearly that the vaginal and uterine microbiome are critical to a patient's success. And in order to get those adjusted, you need to know what's wrong. The best test I'm aware of, and there may be others, but I'm comfortable using Fertility, is the Fertility testing. So to say that it's useless is to ignore a wealth of data clearly demonstrating that the vaginal and uterine microbiome have a huge impact on your outcomes. And we've reviewed that on the show. So I don't know who your RE is, but they are not up to date. God, I'm going to get myself.
No, you should do a show with that guy. Or girl.
Oh, yeah, that would be painful. Yeah.
I'll interview them. I'm like, you don't have to do anything.
Speaking of which, one of the docs from another fertility center, who I'll currently keep quiet, wants to jump on the show with us. So I think we're going to bring her on next week.
Oh, cool.
Okay.
Very cool. Yeah,
so remind me, and I'll put you two in touch.
Okay.
Yeah.
Is there a difference between 2 months of Lupron versus 3 months of Lupron in FET success?
All we know is that 3 months of Lupron with letrozole, don't forget it has to be with letrozole. Alone it's useless because that's being studied, is beneficial. I don't know if 2 months is enough because that's never been studied. I can just tell you 3 has. So we do 3.
Hi, Dr. V.
Okay.
This is just for you.
Just for me. All right. All right.
We had our first day 2 embryo transfer and our first 3 test levels. 170,
Okay.
479,
Good.
1289.
Amazing.
Every other day. Now we're in another 2-week wait until we have our first ultrasound.
Yeah.
We're terrified of miscarriage.
Okay.
This little one, after so much loss already.
Sure.
Would you recommend checking HCG levels while we wait, or any other tests? We thank you.
I wouldn't, because it'll just drive you crazy. But if the stress is so high that it's driving you crazy, sure, go back and get your HCG checked again. Just understand that HCG is, it rises quite quick. Oh, here, let me do the HCG.
Oh, yeah.
Here we go.
They love the fact that you can grow, by the way.
I know.
Like, what a...
So your HCG rises, and then it falls, and then it plateaus. So this point here is about 12 weeks. And it's hard to write with this pen. And so there is a point where it starts to slow down. So depending on how far you are, because that point's about 10 weeks. So depending on how far into your pregnancy you are, you're still early. You can't expect a pure doubling every 2 days. So once it's up to like the 10, 15,000 range, it's not going to double, because then it would be like in the millions by the time you're 12 weeks. So if you're really nervous or anxious, let your RE know and get tested again.
Hi, Dream Team.
Dream Team. I like Dream Team. That's got a ring to it. I like that.
Question.
That's good.
How long do you need to wait after a miscarriage before you can start a retrieval?
You don't. So that's, before you can start a retrieval. Oh, wow, a month, maybe 2 maximum. There won't be any impact unless you were really far into the pregnancy. But once your hormones have returned to normal, you're okay.
2 microdose Lupron cycles done with. First works great, a second busted.
Okay.
What's your thoughts on the next cycle? Repeating the protocol or electrical antagonist cycle? Should mention that my very first cycle was antagonist 300 plus 300 with Cloven, and that didn't work.
Well, 300 is useless, and there's good evidence now that high a dose is actually detrimental. So don't take high dose meds. I like the microdose flare. We do use letrozole now for our patients with diminished ovarian reserve or weaker ovaries, and also when their age is higher. So that's a reasonable thing to incorporate as well. Try the primers. So DHEA, testosterone, HGH, those can all work. Aside from that, there's not a ton more that you can really do. So I like the microdose flare, and if it did work for you once, just because it didn't work in one cycle doesn't mean it won't work again. So I'd probably go back to what you know has been successful for you. Definitely do not take super high dose meds. That is bad. And try Duos.
And Dr. V.
Hello,
NT,
NT.
what are your thoughts on a day-3 fresh transfer? 40-year-old with DOR, arthritis, after chemo with unemployed day 7.
Oh, it's tough. So I generally tell people if they're making more than 2 or 3 eggs, not to do a transfer fresh because your estrogen levels start going up pretty high. Your progesterone levels are going to start climbing. So I try and avoid it there. And if you're in your 40s, you really want to know if those embryos are genetically normal or not. Having said that, there's nothing wrong with doing a day 3 transfer. And there is a whole school of thought that says maybe the embryo does better in you than it will in any lab. And that could be true, but there are studies also that have shown that there's no difference in outcomes whether you do a day 3 transfer or you wait till day 5. So getting the genetics down is probably fairly important to reducing unnecessary meds and expense and time and all that stuff. Are we scratching the surface?
Yeah, surface is scratched. Big scratch. Big one.
All right.
Hello.
Hello.
You know, we were supposed to do a video on this.
Oh,
Is wine totally off limits
yes.
when preparing for FET?
Yes.
Remember what the thing was called?
Oh, drink to your pink,
Yeah.
right? Drink to your pink.
Yeah.
Yes, wine is totally off limits. Do not drink alcohol. It's poisonous and it's terrible for you and it's horrible for your fertility, men and women. Yeah. I actually need to do an angry video about alcohol and smoking because I'm tired of people arguing.
There's a lot of people.
I had a guy on a call recently, and when I said that your smoking is killing your sperm, he was like, "Yeah, right." Like, oh my God, I can't do this
video on that just the other day with smoking.
Yeah, with the Instagram guy. Yeah.
Yeah.
No, we need to do a YouTuber where we or I could do an Instagram where I just yell. Well, no, where I become mean Rahi and I just yell at people. You'll watch that, yeah.
Does beet juice or pomegranate juice possibly affect the uterine lining for FET?
Nobody knows. I've looked that up. Well, beet juice I've never looked up, but pomegranate juice there's no info out there, so we don't know.
But
I don't like I love pomegranate. I don't like pomegranate juice. Do you like the juice?
Sip on it. It's like rotten cheese. You have to eat small bites.
Okay, so totally non-fertility related thing here, but when I was little, because I'm Iranian and we all love pomegranates, we used to take the pomegranate and you would crush it in its skin.
Oh, okay.
So you would no. You wouldn't take out anything. You would just squeeze the life out of it while it was still on its skin, and then you just bite into it, and you'd get all the juice out.
Really?
That is awesome.
That's how you guys do it.
It's an unholy mess, but it does taste damn good.
You don't peel the skin?
You just crush it in the skin because it's tough skin. It's like leather, that stuff.
Oh, yeah.
So you just like push on it, indent it all around, squeeze, and then take the thing and just bite into it, and you get all the juice out.
I'm gonna try.
Just do it like in a bathtub, man, because it goes everywhere.
Everybody should do it on Instagram.
Oh, do the pomegranate squish on Instagram. Yes, we should do that.
Yeah.
You know what? That'd be funny. We should do that. I'll get a pomegranate.
Oh, you could do it.
I could do that. There you go. Yeah. I'm not doing it on this Persian rug, but I'll do it somewhere. Yeah.
What would peptides describe in an FET?
Why or what?
I think it should be why.
Yeah, some people believe, we talked about that earlier. Some people believe that it's beneficial for immune reactivity. There's no data, so I don't use it, but that's just.
When do you know IVF is enough isn't going to work? Is there a certain point medically?
Yeah, that's a fabulous question. And actually, I was thinking the other day we should get a video on this. So, you know that IVF should stop based on the skill of your lab and your RE and the full extent of the different things that they've done for you, and your age and your health and your BMI and all that stuff. So, let me give you an example. If you are a young, healthy patient, and we have tried 3 full cycles of IVF for you, which, by the way, is extremely rare for us, but if I have, then I would tell you you need to change one of the variables, whether it's a surrogate or an egg donor or a sperm donor or a combination of those. Something needs to go or change, because with us, realistically, even after 2 full cycles, there's no reason why it wouldn't be working. And something's wrong, and I can't correct it by that point. Because I don't just keep doing the same thing over and over again. I change it up as we go so that I make sure we're getting the best result possible for you. For other people, is that thing right? Yeah. So for other people or other labs, it may be different. Like, I get people from Australia. For some reason, we're really popular in Australia. Hello, if you're down under.
Terrible.
And they have horrible infertility
Yeah,
care, I know. So if you're down in Australia, they're telling Australian patients not to consider donor until they've done 12 to 16 rounds of IVF. I mean, I I wouldn't be able to sleep at night if I was doing 12 cycles of IVF. So the flip side of that is, if you're 41 or 42 and you've got weaker ovaries, we know ahead of time how many cycles it's going to take to be successful for you. I'm not saying you should do that many, but we know in advance it's going to be a lot. So for those patients, we might do more. So there is a threshold, but it depends on your lab. It depends on the expertise and the outcomes of your clinic and your RE for sure. And it depends a lot on you. And there's an emotional component that's really important for us to be aware of, and we're generally not good at doing that. And there's a financial component that you can't ignore either. It's not fair to tell people to just keep coming back and put money into something that is not necessarily going to work. So there's a lot that goes into it. The one thing I will tell you is my firm belief as an RE, and I don't know if I'm in the minority or the majority on this one, but I'm going to say it anyways. I firmly believe that REs need to be very aware of the fact that for some patients, IVF becomes almost addictive. And they think, I've got a 10% chance. I just need to get into that 10%. And they just keep trying. And one more cycle, please. Can I just do one more cycle? What can we change? What, high dose, low dose, natural, antagonist, microdose. Like, they want to try everything possible because they think that next cycle is the one that's going to get them there. And yes, maybe it might, but the reality is, we as your physicians are responsible for your overall well-being. At least that's my philosophy. And I can't let you harm yourself. So if you're pouring thousands of, after thousands of dollars of, time expenditure, of time off of work, of emotional distress, of, you know, familial problems, of relationship struggles, of all the different things that go into any garden variety IVF cycle, and it's just mounting and mounting and mounting, that's not being a good doctor to let you keep doing that. So I usually tell my patients, if we're going down the rabbit hole of how many cycles we're going to do, we need to draw a line in the sand. That's my phrase. You've all heard me say that ahead of time, so that we're not just going to endlessly do cycle after cycle after cycle. So if you've done 5, if you've done 6, if you've done 3, if you've done 2, whatever it is for you in your situation, we decide ahead of time, when we hit that line, we're done. Either we're changing one of the variables or we're done. Because I'm not going to let you get into emotional distress, financial distress, relationship distress. Part of my job is to take care of you, not just to produce a baby. So if you're doing that, you got to be aware of all the different parts that go into it.
Hi, Dr. Veen. Lupron dangerous for planning to become pregnant. I read that Lupron is dangerous if you're planning to become pregnant, how is it safe to use in a transfer protocol?
It's totally safe if you're using it in conjunction with hormones like progesterone and letrozole or estrogen or whatever you're using in order to stimulate estrogen production. If you take a shot of Lupron and you're naturally trying to get pregnant, you're going to stop yourself from getting pregnant. So yeah, don't do that. That's like the strongest birth control available.
I love everybody that asks this question. I really do. But this comment here,
I love seeing your face when you find something really funny.
yeah. This comment here
Yeah.
is really
Priceless?
Yeah.
Okay.
Where can I buy tickets to the next visit for the set of Fertility Factor?
That would be cool. We could do it live.
Yeah.
You know what?
Husband and I are big fans.
Well, thank you. You know what? This is my office. And there is barely room for Tarek and I in here. You'd literally have to sit on the toilet, which is right over there. So there is no room in here to house anybody. But you know what? Maybe someday we could go to like a New York or a Chicago one day and do a show.
You know what?
That would be cool. You could even do it in Michigan, bring a lot of people.
Oh yeah.
I like the idea. Tell you what.
I would reveal myself on a show. It'd be like the thing.
It would be the thing. So you know what? Message Tarek, DM Tarek. What's your handle? Oh yeah, we can't do that. Oh yeah.
Easy.
Okay, DM me and I'll put you in touch with Tarek via email, and we will see if we ever get to a show. And if we do, we will get you tickets for free. Because that's a great idea. I like that idea. Yeah. That's a cool idea.
Absolutely. I like it a lot. No, free tour. Someday.
I like it.
NRT.
Yep.
What factor could cause an endo patient with 3 Lupron shots not to achieve a? Oh,
I think we did that one. Yeah.
I'm 14 weeks and I have not been consistently taking baby aspirin early in pregnancy.
Okay.
Should I resume and take it daily?
Yes, please. Well, if you have risk factors, yes, please. And make sure you don't have any reasons not to be taking aspirin.
I love your program. Keep it
up. Well, thank you. We love our program. Tarek's very proud of our program, and so am I. So thank you.
Would you recommend laparoscopy to a patient with recurrent pregnancy loss to check for endo? I've had 7 early pregnancy losses, no definite explanation.
Wow.
I have done immunological and RPL testing.
No, endo does not cause miscarriage as far as we know. Now, I would consider hysteroscopy. I would consider fertility testing, thrombophilia testing. I'd want to know what immune testing you did. I need to know your partner, because if he's smoking, drinking, using drugs, is obese, has high sperm DNA fragmentation, that's your problem right there. If you're smoking, drinking, using drugs, that's also your problem right there. If you are in a very low or a very high weight category, that's also a problem. So why don't you reach out and we'll do a consult and I'll figure it out for you. Those are the ones I love. No, it's okay.
Hi, Dr. Vinci. Thank you for hosting this every week to help us warriors. Is there a significance to a full or irregular gestational sac of 5 to 6 weeks US?
Ultrasound. A full or irregular?
Fold or irregular?
Well, it shouldn't be irregular, and I've never heard of a folded gestational sac, but if it's irregular, it could mean a miscarriage, unfortunately. So I would want to know more about what's going on. Probably recommend you follow your betas. So that's a case where you would want to do your serial beta HCG.
Is it much better to use fresh sperm in IVF rather than frozen sperm?
30%.
No issues with sperm, lesbian couple doing IVF with a known donor.
30% less with frozen sperm. Fresh.
At 14 weeks, I haven't had an ultrasound since 11 weeks. Hardly had any symptoms. I felt fully normal since weaning off meds. Any advice for coping with the anxiety during my first pregnancy after IVF?
Do things you love. Do some light exercise, meditation. Yoga is really helpful. Um, Focus on all the baby stuff that you can in terms of, preparations and arrangements. And if you're panicked, just go talk to your doctor and get another ultrasound. Just keep in mind, it's not something we can do every day. At some point, you got to come to terms with the fact that it's going to be okay. And that's not easy. And as Dr. Julia Sen, who did a great video with us, uh, that was a while back, wasn't it? It was like back in the summer. Yeah. She said, patients need to understand that you're going to live in a paradox. It's okay to feel terrified and to feel elated at the same time because you're going to have both of those. You're overjoyed that you're finally successful and you're terrified that something could go wrong. And you need to acknowledge the terror, but put it in its place. And you need to acknowledge the elation and kind of focus on that.
Is putting someone on birth control at the start of the IVF cycle necessary?
They asked us that right at the
Asked us,
beginning.
yeah.
Yeah.
Any benefits to metformin for PCOS without IR?
Yes, there are. Reduced hair growth, reduced acne, improved insulin levels, reduction in your risk of diabetes. There's a lot of different aspects to it.
What can be done for irregular periods to increase chances of conception? No PCOS.
I would want to know why your periods are irregular. Supplements, vitamins, weight loss, letrozole. There's lots of stuff that could be done, but I would need to know why your periods are irregular. If you're becoming menopausal, there's nothing you can do. If you're not becoming menopausal, then I would need the diagnosis. So it could be cortisol levels. It could be, congenital adrenal hyperplasia. It could be PCOS, and they didn't diagnose you correctly. So I need more information on that one.
Male and male. If we do this one, then we got older.
Oh, really? Okay. We missed all the.
No, it was old. I was hopping around.
Oh, you were hopping around? All right.
There's major.
So we did justice to the people that at least asked
They're
us
not
all
going
the
to fire
questions.
me.
Okay.
Because last week somebody got really courageous and said I should get fired.
Oh, did they really?
Well, I didn't read that comment out loud. I didn't think that was appropriate.
Just because you weren't getting to their question?
Yeah, we let get to their
question. Ouch. Oh.
Male and egg quality.
Yeah.
IVF number 1.
Yeah. Okay.
5 medicated IUIs, chemical ones.
Okay.
Should we move on to IVF again or IUI?
Well, regardless of your age, at most you only have one more IUI. So I would probably go back to IVF, but I would need to know more about you. And depending on how severe the male factor is, IUI may be useless. So that's important. Give them 1 more minute.
1 more.
Or 2 more minutes. It's 9:03. Yeah.
It's a comment from one of your followers. Dr. V, you're really behind on your water, according to your water. They're watching, man.
No, I filled it very late today. This was given to me by one of my patients. I love you. Thank you so much, because she knew that I get kidney stones. And this is the kidney stone therapy device. Basically, chug through one of these every day. Tarek and I have both been victims of kidney stones, and and it is not fun. I can tell you that much. So yeah, but I have been sipping on my water this show. That's funny.
Okay, last one.
Yeah.
It's a good. Yeah. Hello, Dr. V.
Yeah.
And fertility intern. People know how to ask.
I love how creative they get. Yeah.
It's wonderful.
Yeah. In order to get your question noticed, you need to stoke his ego.
When would you recommend one move on to donor eggs? I'm 35, healthy, fit, low BMI. I have DOR.
Okay.
I've been standard IVF, dual stim, and natural cycle IVF. I've had a cancer and I have no embryos left. Should I continue to do more IVF rounds or move on to donor eggs? what would you recommend?
I would want to talk to you personally so that I can know the full history to see why you failed and whether or not your embryos were tested. So if all those embryos were PGT tested and it didn't work, then I would be saying to you, they missed something about you, and let me figure that out, and then we can reconsider your options. Because if you had euploid embryo transfers and they didn't work, it may not have anything to do with your eggs. It may be that they're missing something that even with a donor, we're not going to fix. Immune problems, infectious problems, all sorts of things. If they were untested embryos, that's more complicated because then I would assume it's the embryos, in which case going to a donor might be reasonable, but then you don't know. So I would love to spend some time with you and figure that one out together. So reach out and we'll do that. And you're looking like you want to ask another one.
You got hearts.
They got hearts. You're a sucker for the heart. Okay, ask the sucker for the hearts question.
Hello, Dr. ENT.
Okay, you realize you're giving away your trade secrets here, right?
I'm just saying, the hearts is
it's a thing. Okay,
yeah.
All right.
Is there any benefits of taking progesterone and estrogen after 12 weeks? I'm very afraid of miscarriage. My doctor did FET with hormone replacement for 7 weeks.
Yeah, so there's no evidence for the continuation. In fact, there's lots of evidence that shows that it doesn't make a difference. But your placenta does not fully take over hormonal responsibilities until you're about 10 to 12 weeks. So for me personally, I have to admit I do ignore the science a little bit there. We keep our patients on progesterone and oil until 12 weeks, and then we cut their vaginal dose in half and keep them on it till 36 because it reduces preterm labor. And estrogen we keep till 12 weeks if we're using any because we don't use a lot, and then we wean them off of it at 12 weeks. But we're using very minimal estrogen, so we're a little bit. So I would recommend you stay on it for a while. Once the fetal heartbeat's established, it's unlikely you need the estrogen very much anymore. The progesterone I would stay on if I were you. That's just my opinion. Okay, folks, that was great. Thank you all for joining. It was a bit of a lively show. And thank you for the wonderful suggestion that we do a in-person show at some point with an audience. That would be kind of cool. So we love you guys. Thank you for supporting us and our show. And we will see you again next week where we will be reviewing testosterone priming because there's a great systematic review. So we'll talk about whether or not you should be primed with testosterone, especially since I told everyone to stop priming with estrogen. Have a wonderful night and happy Thanksgiving to all the Canadians from yesterday. We will see you again next week. Take care, guys.